Okay, don't go anywhere. We're jumping right back in, and then we'll have a longer break as soon as we get done with this next presentation. But we have this for our next speaker. We have first time with us here at the Carolina Sleep Society, so we need an overwhelming round of applause for her whenever I get finished with this. But we have Tanya Barcinas, who is a dedicated family nurse practitioner with a Doctor of Nursing and Practice degree, bringing her expertise in primary care and patient-centered treatment to her pivotal role at Apnimed. With a passion for transforming lives through innovative healthcare, Tanya specializes in advancing pharmaceutical treatments for sleep disorders such as obstructive sleep apnea. These cutting-edge therapies hold the potential to significantly improve patients' quality of life by enhancing sleep quality. During her presentation, Tanya will share her insights on these groundbreaking treatments, offering a glimpse into the transformative projects. So please give her a warm welcome today. Thank you.
Thank you, everyone. Thank you so much. Robert, what a tough spot. I'm after lunch and before the coffee break. It's wonderful coffee. So please bear with me. So thank you for having me here today and inviting me. I'm very excited to be here. As Robert was saying, I am a family nurse practitioner. I have my Doctor of Nursing Practice degree from Duke University. I live in North Carolina. Luckily, the drive down 95 wasn't too bad, so I was happy. But I am very passionate about OSA and sleep apnea. So this is something I'm excited to be here speaking about today. And I do want to give you a disclaimer, though. I do work for Apnimed, as Robert had mentioned, but my interest in OSA lies with a personal story. My daughter, she's in her 20s now, but growing up, middle school, high school, she was falling asleep at the table. As soon as we get in the car, she's falling asleep. So of course, I'm worried, what's going on? Is this narcolepsy? So finally in college, she goes away to college, goes to UNC Charlotte. It's about a 2-hour drive, yeah, 49ers. And she was just struggling just with that drive. So she gets a sleep test. Turns out she has mild OSA. But these symptoms, and right, she doesn't want to get on treatment. She doesn't want to get on CPAP. She doesn't want to get a device. So what do we do with her? And she's in her 20s and still won't listen to me. So this is something that I am passionate about. Being a nurse practitioner, I've also seen the firsthand effects of untreated sleep apnea. So I want to talk to you today about the emerging therapies and this dawn of a new era. There's a lot of exciting things that are going on in sleep medicine. And what a wonderful time for you to be on this cusp as well of new technology, new emerging treatments. You are the eyes and ears for your patients. After they're getting their tests, they're going to ask you, what do you see? What do you recommend, right? They're going to trust you, before they go to the computer. And it's nice, to just give them, and we work closely with patient advocacy groups. So patients are well aware, they're well informed now, and they know these different options in treatment. So I'm here today to educate you on those. So first we'll talk about the unmet needs in OSA, the pathophysiology, and then we'll go into the different treatments. So we have GLP-1, GIP receptor agonist. Then we'll talk about AD109 and then other emerging therapies. So we'll start first with our unmet needs. So OSA is a disease that affects about 80 million adults. So it's a lot of people in the United States, a lot of people. More prevalent in men, about a 2-fold higher prevalence in men. Also across all ages, so we have young patients like my daughter and older patients, but also across all weight classes too. So not just, when I was in nursing school or, nurse practitioner school, thinking of the typical kind of, person when you think of that OSA profile, but now that's changing, right? So it could be also thinner patients as well, not always our obese patients. And then the symptoms. Bringing awareness now to the different symptoms and how that can affect patients' lives is very important. And the SHINE survey, which is actually something that Apnimed partnered with Project Sleep. So yay, so that's exciting. But the SHINE survey brings awareness to these needs for our patients, our people who are living with OSA. And it's looking at the sleep health inquiries on needs and emotions. So essentially, this was the largest online survey of 1,500 patients living or people living with OSA. And we asked them, what's important to you? What worries you? And what significant burdens do you have from your OSA? And there was a lot, but the most prevalent ones, the ones that they mentioned, fatigue. This was the most common symptom, and it causes impairment in their daily life. Also, social relationships. It's affecting, what they're able to do, to go out with friends, go on vacation, maybe canceling plans at the last minute. And then also, they reported to work issues, so productivity issues, career progression. So it's impacting a lot of areas in their lives. And even mild symptoms, so this isn't just severe OSA, even mild, moderate symptoms, patients still experience these burdens. So just diving down a little deeper into this survey, what were patients concerned about? So highlighted in the dark blue, these are patients' long-term concerns. And we're looking at long-term health consequences. Also, patients are worried about dying. So about 34% of patients are actually worrying about dying in their sleep. And that's concerning. Then we're looking at short-term concerns. And what do we see? We see an impact on everyday lifestyle, the effects of the symptoms such as snoring. And that's, of course, what our bed partners, are reporting there. That's usually why patients are coming in. And then the impact on relationships, impact on work, what others think. There's this kind of preconceived notion of somebody who is living with OSA. And then in red, these are the patients or people living with OSA who have not reported any concerns, and that's a small number, so it's about 8%. So you can see this is concerning, and people are burdened with OSA. And OSA, again, serious disease with health consequences, long-term health consequences. And this being a mother, nurse practitioner, this is where I worry, like for my daughter, right? So even mild symptoms can lead to health consequences such as cardiovascular disease, cerebral vascular disease, neurocognitive impairment, metabolic dysfunction, cancer. And I'm just curious, maybe a show of hands. Do your patients ever express to you this concern, or do they have awareness of these long-term consequences? Who would say they've had a conversation with somebody about these long-term? Yeah, so patients are aware, right? And they are concerned. So looking at the big picture, and I feel like we've already kind of went over some of this data, but just to reinforce, so the prevalence of OSA in the US, about 80 million people are living with OSA. And then of those in the blue who have OSA, only 20% are diagnosed. And then of that 20%, about 3/4 are actually treated. So only 3/4 are going forward, like we just saw, getting treatment with PAP. And then of those who are treated, about 37% maintain it, about 40% underutilize it, and then 23% discontinue. And this would kind of lead into Tammy's conversation or presentation where education is very important. But I know there's only so much, so many of us and the education that can be provided. So really there needs to be something, that we can do for these patients. So looking at the red bars, we have about 80% of patients who are undiagnosed of that 80 million. And of those that are undiagnosed, again, there's this huge treatment need. So what do we do for these patients going forward? And we'll focus now on the OSA pathophysiology, because this ties into our treatments that are available and coming up. So of course we have OSA can be caused by these predisposing anatomic issues. And looking at maybe issues in the nasal cavity with the septum, the polyps, turbinates. There could be soft tissue problems with tonsils, adenoids, the soft palate, also craniofacial abnormalities, pharynx, excess tissue, and then also our tongue, excess fat. So all of these can cause issues, one or combined together. Also, we have sleep-related neuromuscular dysfunction. And this is where some of our new treatments are targeted as well. So, and that can be caused by inadequate neuroactivation of the nerves that stimulate the muscles in the upper airway that keep that area open at night. There could be insufficient response of the upper airway muscles. And then there can also be maybe an issue itself with the muscle, like a myopathy. So when we have OSA, you've already alluded to some of these long-term health issues and concerns. It can lead to serious health consequences. And again, this is what our concern is. So you have either neuromuscular dysfunction or the anatomical issues, or you can have both together. And that can lead to an airway obstruction during sleep. This leads to hypoxic events, maybe a chronic intermittent hypoxia. And then that can lead to other issues such as endothelial dysfunction, which can lead to like a sympathetic surge. So you kind of have this constant fight or flight when your airway, right, is closing, and that can lead to inflammation. This then predisposes you to the heart disease, cerebrovascular disease, metabolic dysfunction, or early mortality. This slide, I'm going to call this our foundational slide. So this is showing where the anatomic issues and the neuromuscular dysfunction for OSA intersect. And we'll see this slide quite a few times during the presentation. So it shows the different treatments that are available for the different targeted area of concern. So for neuromuscular disease right now, we have HGNS, so hypoglossal nerve Inspire. That's approved for neuromuscular dysfunction right now. At the intersection, we have CPAP for both neuromuscular and anatomic issues. And then on the anatomic side, we have surgery, a mandibular device, oral appliance therapy, and the GLP-GIPs. So just a high-level overview of these treatments and PAP therapy. The gold standard, that's the first go-to, that's the standard treatment, and that's always what's recommended first line. However, 67% of patients underutilize or discontinue CPAP in 2 years. And we heard even higher numbers right after that 2-year mark. Surgical therapy, looking at maybe treatment, surgery on the tonsils, the adenoids, and hypoglossal nerve stimulation, addresses that neuromuscular dysfunction, and then oral devices. And then, of course, we have our GLP-1, GIP agonist. So not sure if you all remember last December when our first GLP-GIP was approved, which was Zepbound or tirzepatide. It was crazy. I heard phones were ringing off the hook around that time, so last December. So I know that was, we're almost up on a year for that anniversary. But you know, right now that's the new guy on the block and the new treatment that's been available, and it's designed to support weight loss, which also affects inadvertently, that will affect OSA. So let's go a little deeper into the GLP-G1 GIP receptor agonist. Again, it's focusing on anatomic pathophysiology. And this is an overview. So the blue circle is the GLP-1 and how it works and what it's targeting. So basically, it's helping to decrease appetite, cause a feeling of fullness, also causes weight loss, and then it also affects pancreas, the pancreas by insulin secretion, insulin synthesis, and also beta cell survival. So there's a lot of mechanisms here that this drug is working by. And then also GLP-1 affects lipolysis, so it's breaking down the fat, and then also lipogenesis. So a lot of different things. So essentially, the GIP, it is sending signals to the brain, and it helps essentially mimic the actions of these hormones, these natural hormones, and which then results in weight loss for the patients. And we'll go over those results. But I do want to go over the SURMOUNT OSA pivotal study. So this was the study that Eli Lilly, Zepbound, tirzepatide received their approval off of. And I just want to walk you through the study design, and then just a few notes here that to help take away, because this helps figure out like that mechanism and how it's working. So with the study, there were two groups. So there were two phase 3 double-blinded randomized controlled trials. And these were for participants with moderate to severe OSA, which was an AHI of 15 or higher, and obese patients. And this study was done over 52 weeks. So there was a period, a screening in period, and patients were randomized to either trial 1, which was no CPAP, or they were randomized to trial 2, and they could be on PAP. So in trial 1, they had to be off of PAP, unable or unwilling to use it for 4 weeks before screening. Trial 2, they could be on it for 3 consecutive months, and they had to plan on using it throughout the trial. So patients were then randomized, and then they were slowly titrated up. So every 4 weeks, they were titrated up to what we call the maximum tolerated dose. And that was either 10 or 15 milligrams. They could tolerate that. And the primary endpoint was change in AHI from baseline. So that was the primary endpoint. And then looking at the demographics over on the right side of the screen, we see really this reflects what we would say maybe you see a usual clinical practice for people living with OSA. So looking first at the mean age of the study. So looking at between trial 1 and trial 2, the mean age was about 49.7 years old. And the study comprised of about 30% female patients, mean BMI of 38.8, and it was evenly distributed through the 3 classes of obesity. There's a class 1, 2, and 3. Mean AHI of 50.1 events per hour. And also ESS score, which is not listed here, of about 10.3. This slide is showing the primary endpoints for this study. So the primary endpoint was change in AHI from baseline, and then a key secondary endpoint was weight loss, which is the mechanism that we had discussed earlier. So I'll orient you to the slide. So looking up to the left side, you see A. So A is looking at trial 1, and those are the patients who were not on PAP. And then over on the right side of the screen at the top, we have B, it's label B. So those were the patients in trial 2. So those were the patients who were on PAP. And then down at the bottom, C, this is looking at weight changes. And then D, again, weight changes for trial 2. So just to go over those results, the primary endpoint, again, what we saw in trial 1 was a change in events from baseline. And this is actually looking at the numerical events. And we see a change of about 25.3 events per hour in that group who were not on PAP therapy. And I do want to point out that the mean AHI at baseline was 51.5. So again, a change in about 25 events per hour.
And then when we're looking at trial 2, again, for that primary endpoint, we see a change of 29.3 events per hour versus placebo, which was 5.5 for that group. And then just again, to draw your attention down to the bottom, chart C, this is looking at change in weight, and it's a percentage. So those patients had a change of 17.7%. Again, those who were not on PAP therapy, and those who were on PAP had a change of 19.6%. So again, those are pretty impressive changes. Looking at key secondary endpoints, and again, this is teased out between group 1 and group 2. I'll point out that the percent change in AHI, when we're looking at our treatment group in trial 1, they had a 50.7% change, and then in trial 2, a 58.7% change. And then it's looking at other as well, key secondary endpoints, which were reduction of 50% or higher in AHI events at week 52. So about a 61% change, and then in trial 2, 72%. And what we call, what Lilly labeled disease resolution is next. So these were patients who achieved an AHI of 5 or less, or an AHI of 5 to 14 with an ESS of 10 or less. So that's called disease resolution. And of those patients in trial 1, 42.2% reached that. And in trial 2, 50.2% of patients reached that. And then looking at the last endpoint, it's a change in AHI hypoxic burden. So specifically, and we saw improvements with that as well. Safety. So of course we want to be fair and balanced, and it's important to consider safety too when you're talking to patients, or when they're making these treatment decisions. Specific, the adverse events that were most common in the trial were GI related, which isn't surprising, due to the mechanism of action, and those were diarrhea, nausea, and vomiting. And in summary, for SURMOUNT OSA, so this was for participants with moderate to severe OSA and obesity. So again, moderate to severe OSA, and these were obese patients. And it did lead to significant weight loss and improvements in AHI, as well as a secondary endpoint improvements. So significantly more patients achieved AHI reduction, and what we just saw, 50% or greater versus placebo. Nearly half achieved OSA disease control, and significant reductions were seen in hypoxic burden. Safety was consistent with other studies that were done prior, and GI events were most common. Participants with mild OSA and without obesity were not studied. So you would not expect the same benefit in those patients because of the indirect mechanism of weight loss. And then please refer to the FDA prescribing information if you would like more information, or any particular information that we didn't cover. I'll stop here just to be a little bit more interactive. How many of you had patients ask you about this treatment or option for Zepbound, or are they aware? Are they asking about it or bringing it up as a treatment option? Sleep text, yep. Yeah, so they're not like maybe, just asking or having a conversation when they're like, oh, what are the options that are available, right? Yeah. So, and again, you're the eyes and ears. So, they might be asking you, or, asking after the study, like, oh, what are my options, or what can I do? What's available? So going a little deeper into that, the next on that horizon, that new horizon for emerging therapies, we have AD109. So we were just talking about tirzepatide, that is again FDA approved. AD109 is a combination of eroxabutin and atomoxetine, and it is not approved. It is an investigational product still, and it's not approved for any use in any jurisdiction. So we do need to give that disclaimer. And again, this is the company that I work for. So I do want to, again, be fair and balanced with that. So 8109, again, you might have patients asking about it. So it is an oral therapy that is being investigated for sleep apnea. So again, looking at our foundational slide here, 8109 is highlighted in red, and this is where it would fit into that treatment pathophysiology. It's targeting neuromuscular dysfunction. So again, it is an investigational drug, and it is a combination of two drugs that you may have heard of in the past. It's a combination of roxabutin, which is a novel antimuscarinic and an NCE, or new chemical entity, and it stabilizes the upper airway. So when we were looking at those other slides where we saw like neuromuscular dysfunction in those different areas, it's stabilizing those upper airway muscles. And it's combined with atomoxetine. So atomoxetine is a selective norepinephrine reuptake inhibitor, and its mechanism is to promote adrenergic tone, and this leads to muscle activation. So these two drugs act synergistically as neuromuscular modulators, and it's designed to target neuromuscular dysfunction. So we'll review, a little deeper that mechanism of action and how it's working. So when we have a normal wake-sleep cycle, we have norepinephrine is elevated, and you can see there in the blue dots at the synaptic cliff, and then acetylcholine goes down during the day. So that's a normal during the day, norepinephrine is up, acetylcholine goes down, our airway is nice and open, and that elevated norepinephrine helps to activate those upper airway muscles and maintain that tone and prevent collapse. And then when we go to sleep at night, norepinephrine goes down, and then we have the acetylcholine going up, and the relaxation of those muscles is due to that decrease in norepinephrine. And then there's also inhibition of the genioglossus muscle due to elevated acetylcholine. For most people, this is not an issue, but if you have OSA, then this could be an issue, and you have the airway collapse. So 8109 is designed to specifically target the underlying sleep-related neuromuscular dysfunction with OSA. And how does it do that? So it activates the hypoglossal motor nucleus, and that increases the upper airway muscle tone through the synergistic action of roxabutin and atomoxetine. This diagram is showing exactly what happens. So again, this is an oral medication. It's administered once a night before bedtime. And what happens at bedtime or during the night, now we have norepinephrine going up and acetylcholine going down. So the same diagram that we saw mimicking what happens during the daytime to help stabilize those muscles. I want to draw your attention over to the right. There is a diagram there, and it's looking at V active. So it's showing the placebo, right? There's no response in ventilation there. But when you add atomoxetine 75, we see an improvement in ventilation. When you add the roxabutin to atomoxetine, which is 8109, you see an even further improvement in ventilation. So this is showing essentially that the two work together synergistically. And although atomoxetine looks like it is the primary driver, that combination with the roxabutin helps, again, improve ventilation. This is the clinical development program for 8109. Again, I had mentioned the company is Apnimed, based out of Boston. This research comes from Harvard Brigham Women's Hospital. And the phase 2 study that was done was called Mariposa. We won't go into that for time's sake today, but essentially this was the dose finding trial. It helped us determine what dose to go forward with for phase 3. And in phase 2, specifically the dose that's listed here is the 2.5 of roxabutin and 75 milligrams of atomoxetine, and that was the dose that went forward with the phase 3 trials. In that phase 2 trial, we saw that it improved both airway obstruction and OSA symptoms while being generally well tolerated. It was a 1-month study. Going forward, phase 3 studies, these studies just wrapped up. And the 2 studies, we have Synergy, which is a 6-month study, and then Lunaro, and that's a 1-year study. And again, those studies just wrapped up, and we'll go over those top-line results. And those studies were to evaluate the efficacy and safety of AD109, again, that 2.5, 75 milligram dose at 6 months and up to a year. And then patients also had the option to go into an open label study to monitor safety as well and efficacy over a long period of time. So this clinical development program is designed to evaluate, again, once nightly dosing of AD109 and looking at safety and efficacy. And it's also looking at patients who have mild, moderate, and severe OSA and across all weight ranges as well. So I had already mentioned Synergy and Lunaro, and we'll go over the study designs just to give you an idea of what that looked like. So the study objectives were to evaluate the safety and efficacy of AD109, again, that combination of eroxabutin and atomoxetine versus placebo in patients with mild to severe OSA and across all weight classes. And patients for the phase 3 trials had to have either failed PAP therapy or refused it. So these patients were not on it going into the trial, which is different from our phase 2. Phase 2 patients could have been on therapy, but before entering the trial, but they had to be off for the trial. So looking at the trial designs, again, these were randomized randomized double-blind placebo-controlled trials. And Synergy was our 6-month trial, and Lunaro was the 1-year or 51-week trial. And looking at subjects, so Synergy, the 6-month trial, had 646 participants from 73 states and also in Canada. And then there were 660 patients in the 1-year study from 64 sites across the US. So looking at key enrollment criteria and exclusion criteria, when we're looking at the enrollment criteria for Synergy, and this is the 6-month study, and also for Lunaro, patients had to be 18 or older. They had to have an AHI of 4 of 5 or higher, less than 25% central or mixed apneas. And then also, again, they had to be PAP failures or PAP refusals. And looking at the BMI, so these were patients for men, the range was 18.5 to 40 kilograms. And for women, it was a little bit higher, so we could recruit more women into the trial. And I'll highlight just a few of the key exclusion criteria. Of course, if patients had other sleep issues like narcolepsy or restless leg, REM sleep behavior disorder, they were excluded. If they had bothersome symptoms of insomnia, I don't know, to me, any type of insomnia is bothersome, but these had to be considered bothersome symptoms of insomnia. If they had certain craniofacial malformations, or if there were certain cardiac parameters too that were excluded, such as any cardiovascular disease that wasn't controlled, a resting heart rate of 100 or above, and some other cardiovascular concerns, or if they had a blood pressure of 145 over 90. That was part of the exclusion criteria. So looking at the study designs, they're similar. The only thing that's different is the time frame. So for both studies, there was a screening period of 4 weeks. And then patients, again, these were patients, adults who had an AHI of 5 or higher. And then PSG was done during that screening period. And you'll notice that run-in dose period. There is a period for 1 week where the patients are on a lower dose of atomoxetine. So they're starting off with 2.5 of eroxybutynin and 37.5 of atomoxetine. And then we also have our placebo group. So they're on that dose for 1 week, and then they go up to the full dose, the full treatment dose. And that is the 2.5 of eroxybutynin, 75 of atomoxetine. And if you're wondering why is this run-in dose lower? It's because atomoxetine has reported insomnia with it. And we did see that in phase 2, mild insomnia, but this run-in period with a lower dose helps mitigate that. So again, Synergy was a 6-month study. At the end of that study, patients then had the option to go into an open label extension. So Lunaro, again, same study design. Primary endpoints for both trials were the same. It's change in AHI from baseline, and they were measured at the same time point in both trials, which was 26 weeks. And then study endpoints. So the primary endpoint, just you had said it was change from baseline, and then some key secondary endpoints. These secondary endpoints were focused on oxygenation parameters and OSA symptoms. So some of those secondary endpoints, we're looking at ODI, also looking at hypoxic burden, PROMIS fatigue, PROMIS sleepiness. So these are the top line results from the phase 3 study. So primary endpoint for Synergy, what we saw was a reduction in mean AHI from baseline versus placebo, so a reduction of 55.6%. And then for Lunaro, the 1-year study, 46.8% reduction from baseline. And looking at key secondary endpoints, we saw significant improvements in oxygenation for hypoxic burden, ODI. Again, these are our top line, literally just came out, so we don't have the full data set yet, but soon. And then also looking at select exploratory endpoints, we saw a reduction in OSA disease severity. So remember, these are mild, moderate, and severe patients. So 51.2% of participants in Synergy had a reduction in disease severity, and 45% in the Lunaro study had a change in disease severity. And then those who completed what our definition is for disease control, which is an AHI of 5 or less. So participants who achieved that level for Synergy, 22.3% of patients went to an AHI of 5 or less, and 22.9% in Lunaro. And then again, to be fair and balanced, looking at safety, generally well tolerated. Adverse events were generally mild. There were no safety, severe adverse events that were reported. And the adverse events that we're seeing were consistent with our phase 2 studies, and those included dry mouth, insomnia, and nausea. And also what we saw with these top line results, though, were consistent across the 2 studies, so kind of mirroring each other to support that efficacy and safety. So this is a summary slide, and essentially just, again, to recap what we just reviewed. So AD109 did meet the primary endpoint, which again was that change in AHI from baseline, and we did see that achieved in both Synergy and Lunaro for participants, for patients who have mild, moderate, and severe OSA across a wide range of weight classes. So again, not just looking at obese patients. Again, AD109 reduced AHI by 55.9% in Synergy and 46.9% in Lunaro. And that was 55.6% for Synergy. And then it did meet its key secondary endpoints. So again, significant improvements were seen in oxygenation parameters, and disease control was achieved in both Synergy and Lunaro at 26 weeks. And these improvements also remained significant across the 51 weeks. So it was an effect that withstood the 51 weeks. And then looking at safety, again, generally well tolerated up to 51 weeks. Safety profile was consistent with prior studies, and there were no serious adverse events that were noted. And our last point, looking at consistency, again, these results were consistent across both trials, and this was the largest clinical study, the largest program that has been done for any OSA drug to date, so reporting safety and efficacy of AD109. And I'll stop there. So now we'll go into other emerging therapies. So again, we just reviewed tirzepatide, Zepbound, so that's approved. AD109 just wrapped up phase 3. And then what else is on the horizon? So I think I was talking earlier to Mark, and he's like, I remember AD109, was mentioned here last year. So these drugs, we'll talk about kind of high level overview this today, but who knows, next year. So again, this landscape is changing and rapidly changing. So I think it's important to be aware of all the treatments and what's out there right now. So again, going back to our foundational slide, looking at in red, you'll see Saltium is noted there. So, and its focus is on looking at instability of ventilation. And we'll focus on that next. So looking at this instability and impact on OSA for patients during sleep, the stability of breathing, this process to drive, right, is controlled by different chemoreflexes. And I think Tammy had mentioned earlier, she just gave an excellent explanation of high loop gain, right? But there's this instability with breathing. And this can lead to exaggerated responses and CO2 changes during apneas, and these fluctuations, of course, can cause problems for our patients. So one mechanism to treat that instability of ventilation is the carbonic anhydrase inhibitors. So the mechanism of action for this drug class we'll review. So the carbonic anhydrase inhibitors, they catalyze the conversion of CO2 and water into bicarb and hydrogen, and essentially jointly provide a neural control for breathing based on the elimination of CO2 and, or hydrogen ions. So these drugs have been used for a long time for other health conditions, glaucoma, epilepsy, pulmonary hypertension, high altitude disease. I hear often of maybe somebody traveling to a high altitude who is using one of these medications. So there are a subset of drugs that are being investigated for this particular focus of ventilation, and those are acetazolamide, Saltium, and then some combinations of acetazolamide and Saltium. And how do these work? What are they doing? So it's causing like a bicarbonuria, which then is causing like a mild acidosis, and then that damps the ventilatory response. And to highlight the Saltium, so there was a phase 2 study that was done, and looking at the study design, so it was a 4-week double-blind randomized placebo-controlled dose guiding phase 2b trial. So looking at which dose to go forward with, and it looked at once daily dosing of Saltium versus placebo. And key inclusion criteria is listed. Again, these were patients who had moderate or severe OSA, so moderate or severe. And then again, looking at the different BMI range, 20 to 35. And these were patients though who could not tolerate PAP treatment. So again, they could not tolerate. And looking at the key findings for Saltium versus placebo, the change in events per hour, AHI, the change in those events per hour for the 200 milligram dose group. So there were 2 groups, 200 milligrams and 400. Again, this was a dose finding trial. So that was a change of 20.5 events per hour. And then for the 400 milligram dose group, it was a change of 22.2 events per hour. And then we also saw an AHI percent reduction. So for the 200 milligram dose group, 33.4% reduction, and the 400 milligrams, so a 39.8% reduction. And then patients achieving greater than 50% AHI reduction. Again, in the treatment groups, we saw in the 200 milligram dose group, a change of 25%, and then Salvium 400 milligrams, 40%. And then also changes in O2 saturation. Safety, so again, these drugs, they've been used in various settings for a while. So paresthesias are most common. So 76% versus 18% of patients in the trial did experience that, and headache. No serious adverse events were noted, and the adverse events were dose dependent. So the higher dose seemed to have more of those adverse events. And then looking a little deeper into further treatments that are on the horizon, for time's sake, didn't want to go into all of these, but there's a lot of, again, exciting things that are going on. So other drugs that are in phase 2 right now, Lilly has another triple agonist. So it's a GLP-1 agonist, GIP, and glucagon receptor. So that's in phase 2 right now, retatrutide, and it's for moderate to severe OSA with type 2 patients with type 2 diabetes and obesity. And then they also have an oral drug as well in phase 2. And this is a non-peptide GLP-1 receptor agonist, again, for moderate to severe obesity. I'm sorry, moderate to severe OSA with obesity. And that's orforglipron. I think that's how you say it. And then Salvium, which we were just talking about, carbonic anhydrase inhibitor, and for OSA. And then we have IHL-42X, and that is a drug. It's Inconex is the company, and it is a combination of a cannabidiol and acetazolamide. So that's also in phase 2 right now. And then also Londrastat. So that is Mineralis is the company that has that drug, and it's an aldosterone synthesis inhibitor. So looking specifically for moderate to severe OSA in patients who have hypertension. And then phase 3, we just talked about AD109. And that's, again, those trials were wrapped up. So our last slide, in summary, so OSA is characterized by sleep-related neuromuscular dysfunction. You used to think of it more as an anatomic disease, but now there's this overlap of both. And that can lead to chronic intermittent hypoxia and, again, chronic health conditions. So we know, of course, PAP therapy is efficacious. It's the gold standard, but there are needs for patients who can't tolerate it, who refuse it. So what do you do with these patients, knowing that there can be long-term health consequences down the line? And this is just, an option of the new tools in the toolbox that patients can use. And in participants with moderate to severe OSA and obesity, we talked about tirzepatide and that it significantly reduces AHI and weight, along with key other secondary endpoints. And the safety was consistent with prior studies. And AD109, again, it's an investigational oral tablet, and it targets a neuromuscular root cause of OSA. And we saw, again, significant improvements in AHI and oxygenation and disease control across all disease severities and weight classes as well, and generally well tolerated, and adverse events were consistent with prior studies. And lastly, there's a number of pipeline candidates. There's a lot of exciting things, different mechanisms of action, and a lot of tools in the toolbox that are on the horizon. So that concludes my presentation. My email address is there if you would like to reach out, or if you have any questions, I'd be happy to connect with you. Thank you so much.
Any questions?
Yes.
All right.
So We don't have that data yet for phase 3, but I can tell you phase 2, what we saw in phase 2 in Mariposa. So we did not see with what we saw with just atomoxetine. I don't know if we showed that slide, but atomoxetine alone decreases total sleep time, so about 20 minutes. But when we added the two drugs together, we did not see a change with total sleep time. It does increase, and we saw increases in phase 2 in N1 and 2. We did see some decrease in REM sleep. Does that answer your question? Okay, thank you. Stay tuned for phase 3 results. So, but we'll have more information on the sleep stages.
Another question
Yes.
over here.
Yes.
Is there existing evidence for of OSA?
Gosh, I do not know, to be honest. That's a great question. Yeah, you would have to speak to your sleep provider for that. Yes, I can't answer that, but
I know there has been research for a long time around that specifically, but now in combination with some of the other medication formulations that like Inconex, and there's another company, Respire RX, that is working on cannabis space. There is a cannabis component to their.
yes, yeah. But as far as self therapy, I don't know.
Yeah.
Any other questions?
Of course, if you visit a dispensary, they'll tell you this is everything. That's right. Increased REM sleep.
Increase.
Decreased sleep latency.
Well, thank you so much. I appreciate it. Please take a picture of my email if you have any other questions. Again, I hope this was helpful. And now go get some coffee.
That's right. Time for caffeine. Time for breakfast.